Hello, everyone, and welcome to the Department of Psychiatry and Behavioral Sciences Grand Rounds series. My name is Joe Ceramelli. I oversee Grand Rounds for our department. I want to make a couple of points just about the Grand Round series in general before introducing today's speaker. One is that it's actually not on the slide, but one important point is that we do record and archive these presentations. I know uh, many choose to watch the recording later in the day or on a different day after the presentation. We do archive those on the department website. I encourage you to write any comments or questions into the chat or Q&A. And if we have any time remaining at the end, we could go through some of those questions. There's a group of us that works on Grand Rounds each week, including Samhar Abraha, Mike Walker, and Charles Burrell. Especially, I want to highlight that last point about the hybrid events, which will begin next week with an in-person location at Harborview. I've also recently learned that there are at the different sites around the sort of UW hospitals and the VA, there are groups of people getting together in rooms, creating hybrid events, sort of logging in and having multiple people in a room, many people in a room. So I appreciate that people are getting together in that way already. There's several sources of funding for the series, which I've outlined here. And with that, I'll move on to saying a brief introduction about today's presenter. Today's presentation is by Dr. Benoit Maussaint, who chairs the Department of Psychiatry at the University of Toronto, which is indeed the largest department of psychiatry in Canada, possibly in North America, or even beyond. I have just learned there's approximately 900 faculty and over 200 residents who are trained at that institution in psychiatry. Dr. Maussaint is also the Labat Family Chair in Biology of Depression in Late Life Adults. And over his career has had an overarching goal in research in evaluating and testing treatments for older adults with mood disorders, including treatment-resistant depression, psychotic depression, and bipolar disorder. Dr. Maussaint has received numerous awards for an important and large body of work, including some recent examples, such as the Presidential Award for Distinguished Scientific Achievement from the American Association of Chairs of Department of Psychiatry. Now, today we're very fortunate to hear a forecast, really, about predicting the future of psychiatry from someone with experience in developing novel interventions, testing, evaluating. And I think with that, I'll stop there and turn it over to today's presenter.
Thank you very much. And I'm going to start sharing my screen. Thank you for this kind introduction. And I think that now it works. I don't really have any disclosure related to this lecture, and I don't get any funding personally or for research for any drug company. I use some product, commercial product in some research technology. And I may use, I will talk about antidepressant, antipsychotics, and I will use generic name, and pretty much all the medication I'm going to mention exist in generic form. And so presentation is really rooted, I'm going to talk mostly about mood disorders, our example, but a lot of what I'm saying would apply to psychotic disorder, anxiety disorder, or other disorder. And this presentation was created in 2015 when I became the chair of my department. And people ask me, gee, if you believe that psychiatry is going to change, and you believe that we need to train our residents to prepare for the future of psychiatry that will be different, what do you think will change and how? And it was more like a challenge. They were clearly, some faculty members were not happy about the change I was talking about. So I decided to do a ground round and to present it in our various hospitals to a faculty number. And I structured that ground round with a brief discussion of the past, and then what I consider the present, circa 2015. It has not changed a lot. And then talking about the future. And that's going to be the outline of my presentation. a reminder that rambling and long-winded speech could be an early warning of Alzheimer's disease. And you're going to decide if I'm in the early stage of Alzheimer's disease or if what I say to you makes sense. So if we focus on the past, in the early 2010s, there was a paper published about the most impactful changes in psychiatry over the past 50 years. And they did a survey of 200 mental health professionals over several years, and they asked them to nominate the most impactful changes since World War II. And here are the results: psychopharmacology, deinstitutionalization, fall of psychoanalysis, non-MD professional, neuroscience, SSRI, influence of big pharma, DSM, new diagnosis, and the depathologization of homosexuality. And then the runner-up are interesting. The runner-up were the psychiatry subspecialty, in particular child and geriatric psychiatry, and the economic aspect, insurance, health service, cost of training. But the notable omission, people did not mention much advocacy. They didn't mention the laws and litigation, the discreditation of psychosurgery, the anti-psychiatry movement, or the gender revolution. So that's where we are. If you look 10 years ago and you ask people, tell me what has changed over your career for people who are near the end of their career, clearly, when you look at that list, a lot of things have changed over the career of people who trained me. If you move from the past to the present, okay, I have, so the past, I called it the glorious past. And for those of you who are wondering about the citation there, you may know that Yogi Berra was a famous baseball player, catcher for the New York Yankees, who would say those very pithy statements that appear illogical, but if you think about it, are brilliant. So the future ain't what it used to be. That's about the past. For the present, he said you have to be careful if you don't know where you're going, because you might not get there. And for the future, it's tough to make prediction, especially about the future. So going from the past, so in some sense, the question I tried to answer a decade ago is, what are the biggest challenges in contemporary psychiatry? And here is my take, my answer. So first, again, for somebody like me who trained in the 80s, I saw some astounding changes. And one thing for somebody specialized in mood disorder, particularly late life depression, when I started my career, our main challenge was that a large number of people suffering from depression were not diagnosed and not treated. And so we did a lot of different things to try to improve the recognition and the treatment of late life depression. And as you can see, a survey done in 2017, in brown is the year of my training and early practice, and then in blue was the early 2010. I don't think it has changed a lot since then. You could see that, for instance, in the all general population, 2% of people would say they had taken an antidepressant during the past months, and by in the late 80s and by the early 2010, it would be 11%. And for geriatric, it moved from 3% to 19%, a six-fold increase. So in that sense, we had been very successful. A reminder that people may take an antidepressant for a mood disorder, an anxiety disorder, chronic pain, sleep problem, doesn't necessarily mean they are depressed, but at least it's estimated that at least half of those patients are being treated for depression, probably more than half, maybe 60%. So we have been successful in that way. But of course, the interesting question is, if you look at the marked increase in the provision of treatment for psychiatric disorder during my career, did we succeed in reducing the prevalence of common mental disorder? And because of the invention of the DSM in the 1980s, and that has been pretty much unchanged, we have done some tweaking. I'm part of the committee that review proposal for changes. So we have done those massive epidemiologic survey in rich English-speaking country, starting in the early 80s and coming up to now. And so we can see if at the population level, if we increase treatment fivefold and the treatment work, if you remember a simple equation that prevalence equal incidence time duration for disorder, assuming that the incidence is constant, for treatment work, they should reduce the duration. In the 1900, the hospital where I work, that was a provincial, what you would call a state hospital, the typical patient with a mood disorder admitted to my hospital will be hospitalized for 1 to 2 years. Now they spend 10 days, so 7 days. So you would say, gee, if we have reduced the duration, then the prevalence should have really collapsed. So those 4 authors represent Australia, Canada, the UK, and the US, and they look at those large surveys and they try to answer the question that their title asks. And very briefly, the results are simple. The data show that the prevalence of mood and anxiety disorder and symptom has not decreased despite substantial increase in the provision of treatment, particularly antidepressant. And in countries like the UK and Australia, they have had publicly funded access to psychotherapy initiative. There is more than a million people who receive CBT every year paid by the government, cognitive behavioral therapy in England now. So it's not just medication, it's mostly medication in countries like the US and Canada, but in Australia and the UK, it's also psychotherapy and still no change. So what does it mean? Okay. So here there is a quote from the New York Times a couple of years ago, where a journalist was looking at people with mental health issue, and these journalists, they commented that over the past 20 years, science did little to improve the life of the millions of people living with persistent mental distress. Almost every measure of our collective mental health, rate of suicide, anxiety, depression, addiction, death, psychiatric prescription, went the wrong direction, even as access to service expanded greatly. And if you say, well, it's all diagnosis, it depends on what people report, then you can look at deaths, because that's usually pretty it's not a depending of all diagnostic criteria and how we apply them. So you look here at from the CDC, the Center for Disease Control. In April 23, they released the latest data over 20 years, so 2001 to 2021. And suicide in the US actually increased from 10.7 for 100,000 to 14.1. And in women, it's 4.1 to 6.2, which is almost 50%. And if you look at group like young girls, it's even bigger. Male, less dramatic increase because we start from a higher incidence of death from suicide. And those numbers are per 100,000. If you look at substance use, it's much more dramatic and terrible. So again, when I start now at that point, by the time I become an associate professor in the US, again, CDC data, which are pretty reliable and pretty hard to debate about the data, 6.8 deaths. You can notice at that time, it was about 40% lower than deaths from suicide. And now at the population level, we're at 32.4, which is about 2.5 times the death by suicide. So 20 years of increase of access to psychiatric service and treatment, and we have had very little impact on those public health measures at the population level. So of course, that raised the question from what I call as a shortcut. Now, Irving Kirsch is not really the anti-psychiatry. The anti-psychiatry are the unreasonable people who say to me that schizophrenia is not a biological illness. It's entirely caused by racism. I have people in my department who believe that. People who say medication do not work. So people like Irving Kirsch, PhD psychologist, academic, make a more subtle argument. And he makes this more subtle argument that antidepressants do not work. They don't work better than placebo. So if you believe that argument, then it's not surprising giving placebo to a lot of people. By the way, it should still have an impact on the disease. The placebo has 30% efficacy rate. But anyway, that's what they claim. But fortunately, we have some colleagues who can make their career by meta-analyzing meta-analysis. So you can make now an academic career without ever seeing a patient or a participant in a research trial. You can mine data. And that very important paper from Leutsch and his group look at 94 meta-analyses, 48 drug, 20 medical disease, and 16 drug for 8 psychiatric disorder. And the overall conclusion in the psychiatric drug were not generally less efficacious than other drug. Typical British way to say that actually they were the same or better. You have in blue here the psychiatric medication, you have in white the medication for other medical problem, and you have the effect size. And you can see that the effect size for psychiatric medication is about 10% higher than in general medicine. And the only medication that are clearly better than what we have in terms of number needed to treat are the antibiotics. So it's not that an antidepressant do not work. Now you could say, well, effect size, again, fancy statistics. So my friend and colleague, Dr. Cipriani from Oxford, spent 4 years gathering the data, okay, and 1 year analyzing it. And he published in Lancet. I think at this point we have to stop, okay? He took at 522 trial, pretty much everything, industry sponsor, federally sponsored trial, got the actual data, 116,000 people with major depressive disorder all around the world. And he came to a conclusion that the odds ratio ran from about 2.1 and or 1.4 to 2.1, the antidepressant, and he looked at all the one available in Europe and in the UK and in the US and Canada, and all the antidepressants are, and it's a network meta-analysis, are more efficacious than placebo in that network meta-analysis. You could decide that you don't like it and you want to redo it. Good luck to you. You have 5 years of your life to try to do this. And I suspect that you're going to find the same results. So it is not that our medication and our psychotherapy do not work. And it's not as if people don't get it. I showed you the data that 11% of American citizens have taken an antidepressant during the past month. So why are they not getting better? And in the World Psychiatry paper from John and Al, their conclusion was very clear. They said, they looked at all the reasons. Could it be like an issue of stigma, diagnosis, change in response, propensity? And they said, no, the conclusion is pretty simple. The most strongly, it's still an hypothesis for them. The lack of improvement is that much of the treatment provided does not meet the minimal standard of clinical practice guideline and is not targeted optimally to those in greatest need. I suspect that even though we give antidepressant to 20% of older people in the US, there are still probably half of the people who need them who don't receive them, and I suspect half of those people who get them should not have them. And then if you look at the small interval in the Venn diagram, the small of the people who need the drug and receive them, if I give you an efficacious treatment, but it's inadequately prescribed, it's not going to work. And you may say it's an extreme position. I'm known in my department for taking those so-called extreme position. I'm showing you one study, and you can find a lot of similar study like that. I show it to you because it's published. It's a nice graph making my point. On the right, in yellow, you have the percent symptom reduction on placebo when you're randomized to placebo, and it's about 40%. And then in red and yellow, in blue, you're going to have the percent of people with major depressive disorder that get in remission that the percentage symptom reduction. But by the way, if it was response or remission, you would get about the same percentage. But anyway, that would improve on the wait list. And red is unblinded trial and blue is blinded trial. So they're on a wait list in blue, but they don't know about it, or in red, they're on a wait list and they know. And you can see that doing nothing during the next 8 to 12 weeks, you have about 10, 11% of people who get better. So placebo clearly beat the wait list. But look at treatment as usual. Look at people who go and see a psychiatrist or a primary care provider and are diagnosed and are treated. And that's the only one, by the way, for which the blinded trial is going to beat the unblinded trial. So if you are treated under usual care and you know about it, you are going to have 22% improvement in depressive symptom. If you are treated under usual care and you don't know it, it's a little bit better. So yes, psychiatrist and primary care provider do slightly better, okay, than the wait list, but they do less well than placebo. I tell people in my department, your patient will do better if they come to see me and then they get randomized to placebo in my clinical trial than if you prescribe an antidepressant. And they get offended because I'm telling them that they are not that good, but the data are there. I can show you another study we did of 10,000 patients treated by primary care provider and psychiatrists in the greater Toronto area. We got 20 million to the study. We did it. The results were published. It was exactly the same. It was about 15, actually 17% with the primary care provider, 14% with the psychiatrist of people reaching remission. And the family physician, the primary care provider, treated more complex patients with comorbid medical illness. So that's what I call the mediocrity of usual care. And you can see on this slide on the left that if you are lucky enough to get structured treatment in a study, it doesn't matter if it's placebo, if it's an intervention control like watching video on TV, or an exercise program, or acupuncture, or if it's psychotherapy as a monotherapy or antidepressant or a combination, the treatment work better than placebo, but they also work way better than the same treatment delivered under usual care. So to me, you will remember that I'm the French guy who told you that you do better with a placebo than being treated by a psychiatrist with an antidepressant, and that's called it the mediocrity of usual care. One of my favorite paper at the time I did that lecture, it's a study by Guo et al. Published in the American Journal of Psychiatry, which is, I'm a member of APA. I'm a distinguished life member of the APA, life fellow of the APA. So I've been there since close to 40 years. That association is not an anti-psychiatry association to tell us we're terrible. And the American Journal of Psychiatry is our journal, and they published that paper making the same point, that it was a randomized study. So you cannot say, oh, we see people way harder than the people you treat in your research clinic. We see very special people. Here, they took people who were referred to psychiatrists, okay? And they randomized them. So it's the same group of patients. One group was randomized in green to psychiatrists that use a very simple measurement-based algorithm. And they follow the people for 6 months. In this interesting study, they block the drug. And then in orange, it's usual care. The same psychiatrist, patients are randomly, you may have patients under the measurement-based care, under you do whatever you please. What they told you is you can do whatever you please, but you are limited to 2 medications, paroxetine or the other one was mirtazapine. So you have 2 antidepressants. And you can see that under usual care, those psychiatrists who know how to use antidepressants were able to get a remission rate of 28%. And because they have 2 drugs after 16 weeks, it's flat. Okay? And you can see that if you were randomized the same psychiatrist and the same drug, but the psychiatrist and are tied, they are told what to do by a very simple algorithm I will show you later, you get 72%. I forgot. But anyway, you can see you don't need statistics. And it's the same thing. It's in 16 weeks. So over 4 months, treated by a psychiatrist who use their infinite wisdom to do whatever they please, you have a 28% chance of remitting with your depression. The same patient, remember it's randomized, treated by the same psychiatrist, the same drug, but an algorithm will go in the high 70s. So that's by the way, this is an interesting study. It was done in China. You could say, oh, I don't trust the Chinese data. In the US, we'll do way better. It would be impossible to get the $3 or $4 million that we need to do this trial in the US from the NIH. They will not pay for it. So with a group of people who raise money, and we have done the exact same study. We took the American Journal of Psychiatry study and we repeated it in Pakistan. Randomized patient treated by psychiatrist, same drug, same dosage, same algorithm, measurement-based care versus usual care. We have finished enrollment. We are now having the last patient finishing the 6 months, and I will try to publish a replication, hopefully in the American Journal of Psychiatry, saying, yes, our Chinese colleague, we find the same thing in Pakistan, and now let's look at a rich country like the US and or Canada and redo it. Or I will say, you know what, in Pakistan, the psychiatrists are in usual care do way better. We'll see. We don't have enough replication in psychiatry. That's one of the problems. So again, if you believe I'm a radical, when I did that lecture, that's around the time where Tom Insel walked out from his job at NIMH, National Institute of Mental Health director in Washington, D.C. And so it's about 8 years ago, October 29, 8 years. And at that time, his last block, he said, how do we improve the quality of mental health care? We can do much better by delivering the treatment we have today. We can save lives, many lives, simply by closing the unconscionable gap between what we know and what we do. That's another nice quote. Unconscionable gap between what we know and what we do. What I call the mediocrity of usual care. If it was you or your loved one, your children, your mom, do you want them to, what do you want them to have the 28% remission rate or the 70 some? So this slide, I call it a tale of two approach. What we do, usual care based on fat du jour. Every patient become an experiment and never one. You are trying to match the patient to do personalized medicine, but the wrong way. Or the patient is tired, so I'm going to give them a stimulating antidepressant. Or they have problem to sleep, so I could slam them with a. That's what psychiatrists say. They do their algorithm to match the drug. They try to use side effect at the therapeutic. It doesn't work because if the antidepressant work and the patient take it, after 8 weeks, they are better. They don't like the sedation. They stop it and they will relapse. And when I come to check how you have done, I'm going to find that the patient is depressed again at week 12 or month 6. Patient has lost weight. Let's give them a drug that causes weight gain. They may enjoy regaining the 10 pounds they lost, but then when they gain 10 more pounds, they stop. So ill-advised or ill-timed change of treatment. There are patients who are treatment resistant, maybe 50 some percent, maybe a little bit more in a psychiatric practice. So we know we have to change treatment. And I do a specialized consult for the treatment resistant. Half of the patients are pseudo-treatment resistant. The psychiatrist or the primary care provider panic. Patient was not doing well. The patient, family, the patient put pressure on them and they change something. And they don't optimize the drug. And I tell them, I say, we're going to go back to a drug you took a year ago and we will do it the right way. And if it doesn't work, we'll learn a lot about you. And I've published paper on that. When you go back to a first-line SSRI, like sertraline, people who come label of treatment resistant after having taken 4 or 5 drugs, but never any at the right dosage for the right duration, you're going to have about 30-40% of people who are going to remit. No different in those treatment pseudo-resistant patients and the patient who are treatment naive. If the patient truly have not responded to 2 or 3 medication, you are going to have a way lower response, and you need to do different strategy. And we can discuss, have another lecture on treatment resistant. But in some sense, what psychiatrists do with that anxiety. It's almost like a collective imposter syndrome. That's where I have an advantage over you guys. I know what I know what I don't know. I'm a professor, I'm a chair of a department, and people come and I said, yeah, I'm giving you the best treatment, and there is one chance out of three that it will work. I don't feel bad about it. So I have the confidence that I can. But if you stick with me for a year, and I'm going to maybe I show you those slides, 93% of people who treatment-resistant depression clinic for old people at the end of a year have remitted. 4% have not, and the balance are people who give up and abandon. So I don't believe really in treatment-resistant depression, and I'm not even talking of ECT and psychotherapy. And so again, if you obsess about the drug and the change, you spend all your time with the patient using your psychic energy to the wrong treatment decision that you're going to make, which is exhausting. If you take a systematic measurement-based approach, the computer tell you what to do or not to do, then hopefully the algorithm in the computer is based on evidence and guideline. Then you treat a very large, that's the advantage of a researcher. I treat hundreds of people with the same drug, and then I decide how well it works or doesn't work. I see side effect, and it's really, but if in my practice, I use 4 or 5 antidepressants at most, and I see some colleagues who use all the 20 of them. And so by having a small number of strategy that you implement better, your clinical experience teach you something, and then you keep the course. If a patient come after 6 weeks and they're not better, I say, we are testing the hypothesis that you are one of those delayed or slow responder, and I really want to treat you for the next 6 more weeks before we do any change. We may optimize the dosage, but I don't. So if at the end you have failed to improve after 12 weeks at venlafaxine, and of those 12 weeks, 6 were at 300 milligram, then I say, yes, venlafaxine monotherapy is not going to work for you. But if I give you, and again, I don't even understand how people end up 187.5 milligram for 3 weeks, and then you are so-called a non-responder. It doesn't work. And finally, if you don't have to spend all your psychic energy to think of the next decision, because the measurement-based algorithm is going to tell you, you can spend all your time focusing on the patient and convince them to take the drug, doing the psychoeducation, do the support, preventing the suicide, making sure they take the medication, which eventually they will respond to. So even if you're not a psychotherapist, you can use yourself as a therapeutic tool in the interaction with the patient. So that's the present. And you may be angry. I did that grand round in a local hospital in person, and I can see on the face of my colleague, they didn't like what I was telling them. They were not happy with me. But if we have some time, I would like to know where I'm wrong, and I've been at it for 40 years. I show you the data about the suicide, the death, and it's not just me. So the future, how are we going to change this? Which factor will be impactful so that the next 20 years are not like the past 40 years? So first, I'm lucky or unlucky because in 2017, the Lancet did a Lancet Psychiatry Commission with the world. Can you still see my screen? Because I have a message that my screen sharing is paused.
Yes, we can see it.
Okay, I don't know why I get that message. So anyway, so the Lancet Psychiatry Commission and the World Psychiatric Association decided to do what I was trying to do on my own. Can we predict the future of psychiatry? And here are the 6 conclusions that they came up with. Therapeutic alliance will remain central. Reform structure of service is needed. We need step care, we need teamwork, we need a public health approach, we need to reintegrate with physical care. We will need social intervention and advocacy. Taking a patient with schizophrenia, hospitalizing at $1,000 per day for 20 days, fixing them by restarting the antipsychotic, and discharging them to homelessness doesn't work. They will stop taking the antidepressant and they will be back, and the $20,000 have been wasted. They talk about the evolution of mental health law, and I don't know if you have the same issue in Seattle. I'm reading, like you, what is happening in Vancouver and in San Francisco, and that kind of fight. Do we let patients dying with their right arm? Is it okay to have a 20-year-old honor student at University of Toronto who developed schizophrenia and is now sleeping with her maided hair in their parent kitchen with a knife, and the parents would like her to take an antipsychotic, and they can't, and she's not sick enough to be committed. And at some point, she gets sick enough, she goes to the hospital, take the antipsychotic, wonderful, after 3 weeks, back to a smart woman or bipolar, pick your disorder. But then she goes home and decides she's well, she doesn't want to take the drug, and go back to the floor of the kitchen with the maided hair and the knife. Okay, so that's what I call dying with your rights on. And I don't have, I understand the two sides of the argument, but clearly the Lancet Psychiatry Commission say country where we value autonomy like US and Canada, we need to do more thinking of when do we force people or don't force people to be treated. They talk about digital psychiatry and they talk about implication for training. So that's the Lancet Psychiatry, 2017. Now I'm trying to be modern. And when I was asked to do this lecture, I say, more recently updating it, I said, I'm going to go and ask ChatGPT. And you cannot really, but the question I type in ChatGPT is, what is the future of psychiatry? And you will see that ChatGPT answer, in my opinion, maybe better than the Lancet Psychiatry Commission with very distinguished psychiatrists. They say technology, telepsychiatry, apps, virtual reality will improve access and personalized care. They say AI and machine learning will be used to diagnose and treat. We are, RDoc was from INSOL and the NIMH was a good idea, but it didn't work. But we cannot be stuck with the DSM. I was a medical student already in 1980 when the DSM came out, and it has not changed. Tell me another part of medicine where there have been, we don't have a better understanding of mechanism and cause. The biology is interesting. I'm what you would call a biological psychiatrist, but it's not going to do those answers. So there may be something in between the descriptive psychiatry of the DSM and the biological psychiatry of blood and scanning people. And that's with digital psychiatry to in large number of patients, identify what diagnostic cluster that are better. And I've published, or I'm trying to publish some paper where we do that in my field. And I can tell you it worked better. We put patient in the cluster, and the data-driven approach give us 3 clusters instead of the 2 diagnoses. And then those 3 clusters are better correlated with the genotype and with brain MRI than the diagnostic cluster. So I believe there is some validity in the DSM. We are not completely stupid and clueless, but we now have new tools. We should do better than the mid-70s. Holistic approach addressing social determinants and health, same thing, the poverty and discrimination, and then genetic and neuroscience, identification of mechanism leading to targeted and effective treatment. So as I say, I prefer the ChatGPT. And now I'm going to finish my lecture by showing you my 2015 answer, which is more like ChatGPT than the W Lancet. And a reminder, if you want to predict the future, create it. It's attributed to Abraham Lincoln. I don't know if it's true or not, but to me, it makes sense. For those of you who are in an academic environment in one of the best departments in the US or in the world, you are the one who are trying, and I know you have done it, and you have, I certainly am an admirer of a lot of work that come from Seattle about team care, collaborative care, and randomized trial in your Seattle group to look at various model of care. So I'm preaching the choir, I think.
Dr. Masson, I'm sorry to interrupt. I got a message from Mike that it does seem like your slide sharing might be paused.
Okay, that's what I did. I thought so. I'm going to try again. So anyway, so
Excellent.
I'm going to go briefly so that on your recording we have the slide. So the future, that was the slide about the Lancet Psychiatry and the reference. That's the slide showing the ChatGPT, what is the future of psychiatry. And that's the ChatGPT in readable form. And now that's a quote of Lincoln about predicting the future is to create it, as I know you're trying to do it. I'm a big admirer of what you and your department are trying to do. So circa 2015, I landed on some of the same thing. Yes, we have reduced stigma and we're going to continue doing it, but we have to think carefully of what this means. Yes, there is a neuroscience revolution, but again, what does it give us? And then in the shorter term, the next 10 to 20 years, most progress will have to come through reforming health service to improve access, but also quality. As I've showed you, accessing mediocre service doesn't help you much, and impact of technology. And then I won't have the time to talk about, but if I were 31-year-old graduating from a residency or 30-year-old, I would dedicate my life to prevention. Psychiatry, when I see what has happened when I was young, a medical student, men in my age would clutch their chest and then they will fall down from MI. And it's no longer happening. People like me are not going to die of cardiovascular disease so that we can die of cancer. And it was a triumph of medicine and public health. And with a pyramid, it's not through bypass and heart transplant. It's through a vast public health understanding of mechanism of heart disease and identifying people with high cholesterol, with hypertension, with diabetes, and treating those is through encouraging people through public health campaign to be more active. So I have an envy of cardiology. They deal with a much, much simpler problem. The heart is a fairly simple pump. We can have artificial heart. We cannot yet have artificial brain. We will, but not yet. So reduction of stigma, a few comments. So we have been very successful, but it's to the point of becoming problematic. More than 50% of students met the criteria for one or more mental health condition, including 33% screen positive for depression and anxiety, and 15 with suicidal ideation. Okay, is it credible? Okay, and the same thing applied to psychiatry resident or to medical student, and then now attending psychiatrists. If you take a super group of smart and privileged people who have charm life compared to most of the rest of the population, or will have charm life, do we really believe that 50% of them have an illness? So I do believe we have a mental health crisis, but that's not a mental illness crisis. The mental illness has actually not much changed. 10 to 15% of the population, not 50, 1-5, not 50. And part of the problem of saying everybody is sick, we're back to the era of psychoanalysis. Everybody is sick, nobody is normal, everybody needs a psychoanalysis. And then you have those people with mental health problems who claim for treatment and prevent. People say another one in 6 adults have depression, record rate. It's no, it's not. 18% of adults say they are depressed or receiving treatment, a jump from 7% since 2015 for adults under 30. It's like a quarter. It is not credible. And we as psychiatrists are not helping ourselves. And we are being criticized from within the profession. Alan Francis was the chair of the DSM forum, from outside the profession, saving normal or pathologizing normal. And it has some perverse effect. The increased use of psychiatric language mean that ordinary distress is medicalized, but then the serious things are not being heard. If everybody is sick, I said to my faculty member, our goal as psychiatrists is to take care of people with severe mental illness, schizophrenia, bipolar disorder, psychotic or melancholic depression. We cannot go, there's not enough of us, there will never be enough of us to go in the school to talk to kids who are suffering. Psychologists, social worker, apps need to do it. And there are some data showing that while we're destigmatizing so-called depression or anxiety, the stigma towards severe mental illness are people schizophrenia, bipolar, substance use is actually worsening. And that's this quote: attitude toward milder and more common mental health condition have improved. Schizophrenia, we're actually getting worse. So that's what I want to say about stigma. It's progress, it's great. I've seen it change during my lifetime. But by the way, I still don't see a lot of psychiatrists to come publicly and talk about their own mental illness, like cardiologists or actors do it nowadays. But that's another discussion. Neuroscience. So neuroscience, it works. It's wonderful. I have an H index above 100. I get cited. I have more than $170 million of funding, direct cost on my CV. I've done a lot of work, a lot of paper, but we are the elephant and the blind man. We are getting at something, but we don't really understand how it works. We still don't understand. Nobody can tell me why having a depression at age 30 and then you get treated and with psychotherapy and medication, you get better. Why does it double your rate of dementia 40 years later when you're 70? Nobody can explain that. That's the kind of work I do. And it's because we have no explanation. By the way, the reviewer of grant and paper are not eager to give us money to study it or to publish our paper, but they are very strong. So we have learned a lot of things. We don't really understand it. So, and again, Thomas Insel, who was a leader in biological psychiatry at the NIMH for like close to 20 years, scientific progress in our field was stunning. But while we studied the risk factor for suicide, the death rate climbed 33%. While we identify neuroanatomy of addiction, overdose deaths increased by threefold. I showed you the data. While we mapped the gene for schizophrenia, people with this disease were still chronically unemployed and dying 20 years early. So again, and he published a book on this topic, Healing the Crisis of Care in American Mental Health. My friend, Eric Lenz, was one of my fellow long time ago and is now the chair at the other University of Washington, the one in St. Louis, gave me that slide 10 years ago. Why is it so hard to do personalized or precision psychiatry? Because you need to know the pathology to do precision cancer, you need pathophysiology, and therefore to explain the heterogeneity, and we don't have it. You need to characterize the illness and the response close to biomarker. We cannot do that. You need very large sample. I'm not talking 300, I'm talking 30,000, and we don't have that. And we need a precise measurement of outcome, and our scale are good, and they were good enough to show that antidepressant and antipsychotic work in the 1950s. They are not good enough for precision psychiatry. And he called that the four horsemen of precision psychiatry apocalypse. So yes, neuroscience, we made some progress, but not enough. Trying to move faster to a 5 minute for question. So you are the world expert for the reform of mental health service. You have taught us a lot from Seattle and Washington. A few observations. We have provincial data. So because we have one insurance covering 100% of our population, and all the doctors have to build the same insurance, we can look at those kind of things. If you look at what that pie chart very quickly, we are replacing older male like me with younger male and women. So if you look, my generation, it was 2/3 male, 1/3 female, and now psychiatry residents are more like 50-50. Regardless of the age, women care more about their patient. They provide better care, which means they spend more time with their patient. They see them more frequently, and which means your people like me, the older guy, are retiring, and we're going to be replaced by younger women. And you need the three or four younger women to replace two older male. And so actually, we are not training enough people, and we won't train enough people to even replace the older psychiatrists. So that's something people don't talk about it, but because it's considered politically incorrect. And I'm not, I'm very happy that 50% or more of our residents are women. In the change, it was identified in one of my first slide, moving from a purely male group of professionals to an equitable, fairly balanced group is wonderful, but it has some consequence we're not talking about. This one, 1819 Vienna, 2020, I could have said Seattle. This one is for the St. Louis. And pretty much we have not changed our model enough. And somebody enter in a room, we talk to them for 30 minutes, 45 minutes, some magic happen, they leave and they're better. That one-on-one psychiatry doesn't work. And if you say, what is Persilin, Tide, and Surf? It's CBT, PST, CBSST, ACT, IPT, all the acronym for the psychotherapy and the psychosocial intervention. We have, the model has not changed enough, and it's not going to solve the crisis. Again, if you think I'm an extremist and an unreasonable person, the president of the American Psychiatric Association in 2019, I'm going to rest my voice, let you read, and but basically arguing for what you're trying to do, team-based work, psychiatrist maybe as a leader of the team, but if you supervise 4 social workers who each see 40 patients and you meet your 4 social worker an hour a week, and I did that in the kind of collaborative care, the thing that are well known in your environment. In 1 hour, I can reach 160 patients. We send them every 3 months, and therefore 600 and some patients in 1 hour of my week. That's the kind of practice we'll need, plus technology, plus telepsychiatry. And this was before the pandemic. So we're, in that sense, lucky that the pandemic has forced us to do very rapidly the change that nobody wanted to do in 2019. One of my good friends, the first fellow I had in Pittsburgh in 1990, Dr. Mark Koenig, became a health service researcher for the VA. I show you one paper. He randomized older patients with anxiety disorder to be treated by either a PhD psychologist and CBT or a lab provider, a university graduate who does 40 hours of training for CBT. No difference. Actually, slightly numerical advantage for the lab provider because they don't know anything else and they stay on script. Quality, I've shown you this slide, measurement-based care. Here is the algorithm. I'm going to show it to you so you have it on your recording. Very simple scale, very simple decision. That's the whole algorithm. When you change drug, when you change dosage, the very definition of, you remember you have only 2 drugs and you have 3 dosage. And that I told you, my 5-step clinic, 80% of people getting better. So I'm sorry, I was wrong. I said 90-some, but 87% people after 1 year with a combination of psychotherapy and medication, older patient with treatment-resistant depression, 4% who don't benefit from the year of treatment in our clinic, and they still have TMS and ECT and ketamine and psilocybin. That's just like standard FDA-approved medication plus psychotherapy, and 9% who drop out. So I don't believe in treatment-resistant depression. I told you that. And then the impact of technology. That slide is old. You're in Seattle. I don't need to talk to you about technology and Uber and Netflix, Airbnb, Facebook, your banking online. But in psychiatry, as I showed you, we have not really embraced that. The lawyers are starting to embrace less costly workers supported by technology or standard process or lay people with online self-help tool. That's for law, okay? The future of the profession, but it's coming for us. And you have seen that people prefer the recommendation of ChatGPT than physician, but not by a little bit, okay? 78.9% prefer like the recommendation from the chatbot versus 22%. And sorry, it's not the preference, it's professional blindly rating the quality of the recommendation. Again, the mediocrity of usual care. And empathy, 45% of the chatbot, 5% of physician. That's a clunky story of our colleague at Dartmouth who tried to build a robot psychotherapist. He tried to do PST. He taped himself for 2,000 hours and tried to have a response for anything that a patient could say in a PST. It was clunky, it didn't work, and it's not being adopted. And he was trying to solve the issue of rural community in New Hampshire who don't have access to psychotherapy. But that's a reminder. I'm showing you in 1973 in New York, an engineer from Motorola with the first call with a handheld cell phone calling AT&T. The prototype was 2.5 pounds. You could talk for 35 minutes after charging it for 10 hours. And 10 years later, when they did their first commercial product in 83, it was costing $4,000, which is $10,000 today. And you know how the clunky, too expensive phone that didn't work end up, all of you have one now in your pocket. And so the robot psychotherapist of the 2000 that didn't work doesn't mean that it's not doable. And I show you, why do we ask our patient, how did you sleep during the past months, as opposed to download their data? Why did we ask them if they were exercising or moving? Why don't we do ecological memory assessment instead of the PHQ-9? So anyway, that's you can buy this one online for a few $100 for your TDCS at home. And finally, finishing, I didn't talk about this, but I'm still an academic at heart, and all those things I've talked about need to become evidence-based and need to be tested. And even though my younger colleague, as I said, want to analyze data and database and population data, in the end, read the two quotes, the Churchill about democracy and my quote. And I'm sorry, I thought I was doing the lecture. I have been invited to do this ground run at WashU in St. Louis, and I mixed up the two WashU when I updated the slide. It should say Washington University in Seattle about the RCT. Anyway, that's the end of my lecture, and I'm happy to, if we have 1 minute, and to answer one or two questions. If you want to stay, I can stay as long as you want to answer a question, but some of you have to go and work and see patient at 1 p.m. Thank you for your attention. Good luck in your practice.
Well, Dr. Masson, thank you for walking us through this, just describing the ideas of the future. You're right, we don't have a lot of time. Coincidentally, Eric Lenz will present in our Grand Round series next month. So you actually gave a nice introduction to what's coming next month. I do wonder, maybe if I just pose one question. Much of the discussion, understandably, is about treatments, and I wonder what you think about diagnosis.
I did mention it. I did in one slide. Maybe I will repeat. I believe the descriptive diagnosis of the 1980 were great, but it's close now to 40 some years later, and the biological psychiatry is not going to give us diagnosis for a variety of reasons. That's a different lecture. So we need to find a new way in between, and I believe that it's a data-driven approach. We need to identify new diagnostic cluster. And I believe that it's through those portable and another type of data. And as I say, I'm part of a group in Toronto, and there are people around the world who are trying to do this. So stay tuned. You will know in 5 years if we can come up with an alternative. RDoc was conceptually a good idea, but I don't think it's going to work. So it's something in between descriptive psychiatry and biological psychiatry. It's data-driven, and it's using technology. I believe that if you are a 30-year-old, hopefully the DSM-6 or 7 will be based on a different, and our cluster are not bad. I mentioned that our diagnostic cluster are not bad, but the data-driven cluster seems to be better and better correlated with brain imaging and genotypes.
Thank
you for your attention, and I know you need to work. I'm sorry I didn't leave enough time for questions, but I felt pressure to try to convince you, and maybe I did, maybe I didn't.
It's interesting. I mean, I think you've raised a lot of you've provoked in many ways regarding usual care, regarding ideas for, like this comment you made, people randomized to placebo might do better than what's happening in usual care. It's interesting to really think through this and challenge us to consider the ways that we're delivering care and how we can improve that with treatments that we already have. We already have easy access.
Absolutely, yes.
Yeah. So
Thank you again.
thank you very much. Well, take care.
Bye-bye.